I see a wide variety of women with concerns and issues, and frequently I see people who have abnormal imaging, but very commonly women who feel that they have lumps that haven't been evaluated yet, people with family histories, nipple discharge, changes in their breasts that they're not sure they can explain them. Those sorts of things come in here all the time. When women are having a lumpectomy for breast cancer, there's always a concern about the margins, whether there's any microscopic tumor cells at the edges of the tissue. The way I explain that to people is it's a little bit like biting an apple and seeing half a worm. You've left some of the worm. The same thing happens with breast cancer. Some of these cells are microscopic and you can't see them. So particularly with ductal carcinoma in situ, which is microscopic disease inside microscopic ducts, I can cut through that and not know it. And nationally, re-excision rates after lumpectomy, which means the patient has to go back to the operating room and have more tissue taken out, range very widely, but between 30 and 47% nationally. So a lot of women are having additional surgery after they've had a lumpectomy to clear their margin, to make sure all the tumor is out. So we've worked very hard in a multidisciplinary way at this hospital to decrease that risk. Because really the only way to make sure your margins are going to be negative the first time, every single time, is to take the whole breast off, and that's going backwards in time. So our radiologists have started taking pictures of the tissue I take out in two views. So what they want to do is if a patient's had a biopsy, that's why they're in the operating room, they have cancer, so there's a clip left behind. They want to make sure the clip and any mammographic abnormality is well within that specimen with normal looking breast tissue around it. They then turn that piece of tissue this way to make sure that it's not close to this surface or this surface. These pieces of tissue are inked on different sides so the pathologist knows exactly which way is up, down, left, and right. And if we can establish normal mammographic breast tissue around a mammographic abnormality known to be a cancer, then we decrease our re-excision rates. And in using this two-view specimen radiographs, re-excision rates at the breast center are down to 15%. So a marked decrease. Now I did check my own re-excision rates prior to the two-view specimen radiographs, and it was 27%. So down to 15%. I'd like it to be lower, and we're always looking for ways to decrease that because there's a lot of phone calls I don't like making, and one of them is calling the patient who just had breast cancer surgery to say, guess what, we get to do this again. So both from the patient point of view and my point of view, it's a win-win situation. So I think that's it's a wonderful program, and I'm glad that we're doing it. The minority of breast cancers in this country are attributable to genetic mutations in two genes called BRCA1 and BRCA2. And not everyone is tested for them. We really need to screen our population to see who's at risk for these mutations so that we're testing the appropriate people. We want to identify these women before they get breast cancer because there are things we can do to decrease their risk of breast cancer, and there are ways of aggressively following them so that if they do develop a breast cancer, we find it at a very early stage when it's more likely to be curable. So in our mammography department, the receptionists hand out a screening tool to each patient who is free to fill it out or not. And if women have a family or personal history suggestive of a mutation in one of these two genes, they get a letter that says, hey, you need an evaluation, you need a risk assessment, and potentially genetic testing. And by identifying those women who are at high risk, then we can treat them better so that we can find breast cancers at an earlier stage, or actually we can prevent breast cancers with certain medications and other things. So it's that's a wonderful program that I think a lot of people have benefited from. And nationally, it's approaching 50% of women have mastectomy for early stage breast cancer. So we're preserving a lot of breasts in this hospital. I can't put them back on after they take them off. So it's an irrevocable decision, and lumpectomy is outpatient surgery. They're going to live just as long if they have a smaller operation. So I'm a big advocate for breast conservation if it's a reasonable thing to do. I think there's a real attention to personal care in this hospital. It is not unusual when a woman has a biopsy in radiology for me to get a phone call from the radiologist, him or herself, or from the staff saying they've just gotten a pathology report and can I accommodate the patient that afternoon. They will often come in to get their biopsy results from the radiologist. So we make a space so that that patient can be informed of her diagnosis and come here and get some information. I think that makes things a lot less scary when you have good information right at the get-go and go home and really don't have anything to think about besides the fact that they think they're going to die. And most of these women are very treatable. The staff in our radiology department will walk the patient up here. So we see the staff bring the patient up, and I think that is a kind of personal attention that is very rare these days.